but you are basically providing a scaffold. That is, I think, really important when we are dealing with structural defects. All right, so moving on into our adipose tissue. So a few different terminology here. So lipoaspirate is the term that we're going to use for the fat that we collect after our mini lipoaspiration. I like using the term lipoaspiration as opposed to liposuction because it differentiates us from doing cosmetic procedures, because as you guys know, none of this is cosmetic. This is all for pain management purposes. And then we can take that lipoaspirate and we can do different things with it. Some people will call this lipoaspirate macro fat, just because of the size of the fat globules that are present there. And then we can mechanically resize it into microfragmented adipose tissue. So this is where the lipoaspirate has been processed mechanically down to around 1.2 millimeters or less in size. And the purpose of this, the microfat, is to maintain the 3D scaffold. We want that 3D architectural structure where you have mature adipocytes, you have the cells that are present in the stromal vascular fraction, you have fibrous scaffold, you have capillary fragments, you've got extracellular matrix, so you're going to have things like hyaluronic acid and glycosaminoglycans, but you are basically providing a scaffold. That is, I think, really important when we are dealing with structural defects. So you have a partial thickness tear in the supraspinatus tendon, or you have a partial thickness tear of the patellar tendon, and there's an actual defect there where we want to fill that defect with something that occupies space for a period of time. Yes, it'll eventually get taken away as the body breaks down the tissue that was injected in, but it's staying there for longer than a pure fluid would, like the bone marrow or PRP or PPP or anything else like that.